What a tough talk to debate, especially when you're up against a Supera guru like Lawrence. So anyway, so my job is to try to sell you the stents in the popliteal area. These are my disclosures. So we all know this. The vessel is a very different animal in the popliteal artery. I think it's important to distinguish between the P2 and the P3 segment. And this area of the artery undergoes plenty of flexion and many conformational changes and in terms of length as well. This study showed that there was actually a fair amount of compression in the distal popliteal artery. So what are the treatment options? Well, you can see a whole bunch of options that are available, but none of these options are really great. In fact, trying to research the talk really put into perspective that I wasn't really doing stuff that had a lot of science behind it. So question of leave nothing behind. Lawrence has said that there are some DCP trials, but specifically related to the P2 or the P3 segment of the popliteal artery, which is commonly regarded as a real popliteal artery, there isn't a lot of data for drug-coated balloons in this region because naturally this is a tough region to run a trial on. One of the biggest studies that I had with stents in the popliteal artery was the ETAP randomized control trial. So this was the BART live stent. So this was PTA with provisional stenting versus primary stenting, although there was a crossover about 25%. And these patients were followed up to 2 years and recently published in 2015. And what we could see was that the authors concluded after 2 years that between the group that had a primary stent versus those that had a provisional stent, stenting seemed to have a suggestion of slightly higher patency rates, albeit not significant. Stent fractures were also fairly high in numbers, of 7.8% at 24 months. Of course, this is with a very traditional stent, which is a live stent. The Supera has been widely known and widely studied with excellent outcomes in the SFA and the popliteal artery and with high kink resistance. This is one of the first few single-center studies demonstrating the efficacy of the Supera stent in the P2 and the P3 segment, which represented almost 60% of these lesions. As you can imagine, these lesions were short because, of course, the popliteal artery is short. And with this single-center series, very reasonable and good patency rates of 87.7% by duplex ultrasound, PSVR 2.5, and when surveillance of these stents on X-ray, and none of these stents seem to have any significant fractures. Freedom from TLR was actually good at 86% at 3 years. Just trying to summarize all the stents for the popliteal artery, you can see that in the top 3 rows, a couple of early studies with previous generation non-woven stents seem to give you a primary patency of around 70%, but clearly in the more recent studies with the Supera stent, you can see that delta has grown to about 10 to 20% more than 70%, and I think it's this that many of us are actually using this stent for the popliteal artery. And I thought to try and beat a cardiologist, I'll try to fish out one of these bad legs that we did. So this is a patient with a critical limb ischemia. By all intents and purposes, this leg needs to go into a box. So this was a SFA and popliteal CTO that was recanalized through a retrograde technique, severe calcium, and with adequate pre-dilatation, a 5.5 Supera was implanted in this patient, and subsequently with the amputation of the toes and negative pressure therapy and good old-fashioned wound care, we managed to get healing in about a year, and on follow-up at 3 years, he remains prosthesis-free and is walking independently without an aid. How about drug-eluting stents? There actually isn't any data for drug-eluting stent in the P2 and P3 area. The Munster registry, as you can see, is one of the earliest registry with Illuvia stent, had a small number of patients in the P2 segment, and with that, they were able to get primary patency in the SFA. Our registry that I recently I presented yesterday was drug-eluting stents with Illuvia stent. In our series, we had approximately 30 to 50% of patients with P2 and P3 involvement. And these were 6 millimeter stents placed in slightly undersized, well, severely oversized in a 4 millimeter artery. And with that, with a 6 months primary patency, we were able to get it at 91% and freedom from TLR at 95. One wonders what would happen at 1 year with a high number of these very complex lesions. Just a typical case that we had, a patient in May 2018 with a popliteal CTO that was recanalized in an anterograde fashion, drug-eluting stent in the trunk, pobar of the anterior tibial artery, and drug-eluting stent in the P3 segment all the way into the P1 segment. And we were fortunate enough to have a control angiogram in about 5 months, and with that, we were able to see no significant restenosis, and this patient continues to be followed up. On duplex ultrasound, we saw no aneurysmal change, as you can see, well apposition of the stent to the popliteal wall. So in summary, stents are necessary to treat tough popliteal lesions. My treatment algorithm is if it's small and short and simple drug-coated balloon, avoid stenting. If it's short and complex, certain vessel prep with whatever you have, drug-coated balloons and provisional stenting. If it's long, it's usually complex. It has a good size vessel. I'll prep it and I'll put a Supera, which is a dedicated stent in it. If it's long and it's, again, usually complex and it's a small vessel, maybe in a female, aggressive vessel prep, drug-coated balloon, and maybe a drug-eluting stent if the results in our series prove to be good. Thank you very much.